pleasure now to introduce our last speaker for this session, Dr. Deborah Shatzkes, who is also head of head and neck radiology at the Leonx Hill Hospital, and she'll be speaking to us about sinonasal neoplasms.
Okay, good morning. I'm Suresh Mukherjee from Michigan. It's me. It's Debbie Shatzkes from New York. So we'll finish up this morning's session talking about sinonasal tumors. And I see a lot of these in my practice, and I think it's always important to maintain some perspective, really what the scope of the problem is. And the truth is, luckily, that sinonasal tumors are really quite rare, only affecting about 2,000 Americans a year. And some of these are fairly benign acting and indolent, but others are very, very aggressive. I think the biggest problem with the diagnosis and ultimately treatment of sinonasal tumors is the fact that the symptoms can be really identical to that of just routine chronic rhinosinusitis, nasal stuffiness, nasal discharge, headache, facial pain, really nonspecific stuff that affects millions of Americans every day. The problem with sinonasal tumors and their location is that, as Nancy mentioned in the nasopharynx, they abut some really critical structures, the orbits and the intracranial compartments. So when there is delayed diagnosis, the implications of that can be extremely serious. So overall, there's generally a pretty poor prognosis, a combination of some aggressive histologies and this very late presentation. So what I'll try to talk to you about and emphasize in this talk is what our role is in the diagnosis and management of these patients with sinonasal tumors. We'll talk about a few benign and malignant sinonasal tumors. We'll look at, I think, the most important contribution that we can make in managing this patient, which is accurate pre-treatment mapping. And then finally, we'll discuss a little bit of how we can effectively follow these patients to look for recurrence. So again, I do want to emphasize where we fit into the clinical picture in managing these patients. We, I think, as radiologists, and part of what's fun for us is to try to figure out what tumors are, and we look at it, and we have all our different imaging features that we can look up and say, ooh, it has this signal, oh, it has that diffusion. But the fact is, most sinonasal tumors look virtually identical, and there's a really enormous overlap in imaging features. So no matter how much time we spend trying to figure out what things are, ultimately these are all going to get biopsied, and the diagnosis is going to be made histologically. So really, our primary role, our primary contribution is accurate mapping. So the mapping of disease extent, really very, very careful mapping, whether the patient is going to go on to surgery or to radiation therapy. Our primary contribution is to find all the little nooks and crannies of the disease, the places that it will spread that may not be accessible to clinical examination. That's really our major contribution, not so much trying to figure out what the tumor is. But of course, we want to at least, in the preoperative or pre-biopsy setting, offer some information about, what is the likelihood that this is going to be something malignant? Do we have to, consider addressing this in an oncologic fashion? So can we at least tell benign disease from malignant disease? And, we can, offer at least some information. None of it is foolproof. Multiplicity can be very helpful. So, the most common mass that we'll encounter in the sinonasal cavity is going to be just the polyp, and polyps are more commonly multiple than single. So if we see multiple masses in the sinonasal cavity, chances are it's going to be benign disease. We can look at the margins. We can see if something is very infiltrative, and otherwise if it's well demarcated and just kind of pushing. And that's helpful, but unfortunately not completely foolproof, because many malignant sinonasal tumors can be relatively well demarcated, kind of more expansile, and in contradistinction, lesions that are benign appearing can also be very malignant. And then finally, we can look at bone changes. We can look at whether the bone appears remodeled or does it appear, frankly, invaded or destroyed, and certainly that's going to be some helpful, but again, not foolproof information. So if we see, as in this case, a solitary invasive mass associated with bone destruction, it really has to be considered malignant until proven otherwise, and of course it will be proven one way or the other on the basis of the biopsy. Of course, including this information in our report will be helpful in at least developing some initial gestalt for the clinician as to what we're looking at. So we have a number of imaging options, as usual. We can look at CT, which is, of course, always best to look for the pattern of osseous change. And some tumors do have some characteristic calcified matrix, for example, chondrosarcoma. But, again, in most cases, the CT bone changes will be fairly nonspecific. MRI is always best for mapping these tumors because it can tell the difference between enhancing tumor, non-enhancing secretions in the sinonasal cavity, the appearance of mucosal thickening, which of course looks different than tumor. The extension of these tumors outside of the sinonasal cavity is, again, one of those key features that we bring to the table that we can do much better than the clinicians. And MRI is clearly superior to look for orbital or intracranial extension. And then, as we'll hear a little bit later, perineural tumor spread, really MRI is the only way that we can accurately do this. What about PET-CT? This is kind of one of my pet peeves. I've got surgeons that I work with who really insist on kind of following everything with PET-CT. They think it's kind of, if you throw PET-CT at it, you're really bringing out the big guns. But unfortunately, it doesn't work that well for a variety of reasons in sinonasal tumors. One is that not all of these tumors are PET-avid. So, for example, adenoid cystic carcinoma, as in the salivary gland, occurs in the sinonasal cavity, and it is notoriously kind of unpredictable with regard to PET avidity. So if the primary tumor was not PET avid, then using PET-CT to follow that tumor is, of course, going to be a waste of time and very dangerous because you're going to miss recurrences that you just can't see because they don't take up the radio tracer. The other problem with using PET-CT to follow these patients, or even initially staging them, is to look for perineural spread, and we know that PET-CT is completely unreliable. So ultimately, in my opinion, there is some complementary roles to these imaging studies, but MRI is absolutely necessary in malignant sinonasal tumor to accurately stage and, again, define the full extent of disease, which is our primary role. So, MRI is not without pitfalls, and we love to consider pitfalls. Here's a patient with a mass. It spans the posterior ethmoid and sphenoid region, so a sphenoethmoidal mass. T1 post, it's very bright, appears to be enhancing avidly. On T2, sort of a moderate T2 hyperintensity, certainly doesn't look inflammatory, which will be very bright. So, it looks, on the basis of the sequences, we see a sphenoethmoidal enhancing tumor with moderate T2 hyperintensity, certainly suspicious for something like a squamous cell carcinoma or other lesion. But when we look at the pre-contrast TB1, we see the tumor is actually only in the ethmoid, and what we're looking at is a mucocele in the sphenoid sinus giving you that bright T1 signal. So, and this turned out to be an ethmoid adenocarcinoma with a secondary sphenoid mucocele. And we often see post-obstructive mucoceles in association with sinonasal primary neoplasms or as a complication of postoperative treatment. And the moral to this story, and what I've learned over the years, is I really have to use all the MR sequences when I'm using MR to look at these tumors to tell the difference between secretions which can look so different. We've all seen high T1 signal material, low T2 signal material. That's related to inflammatory disease, so you really have to look at pre and post contrast T1 as well as T2 weighted imaging. So let's look at a few benign and malignant sinonasal tumors. As I mentioned, inflammatory polyps are the most common masses that we see in the sinonasal cavity. These are not tumors, they're not neoplastic. They're just heaped up or buckled mucosa. And again, they are much more commonly multiple than single, and it's a comforting thing when you see multiple masses like this in the nasal cavity. We should remember, though, that when they get large, they can exert pressure effect, mass effect, and they can remodel bone, and particularly when they coexist with allergic fungal sinusitis, as in this case, there can be an enormous amount of bone destruction, and this looks, really, really aggressive. A lot of high density, centrally characteristic of allergic fungal sinusitis, but look how much bone destruction and remodeling. And this is the kind of thing, I think there's two entities in the head and neck when I show the residents and say this is benign disease, they can't believe it. This is one of them, and the other one is those huge thyroid goiters that kind of take over the whole head and neck, and they look so awful, but they're benign. AFS is another one of those kind of things. So the inverted papilloma is a really interesting lesion, and it's one of those where we can suggest a preoperative diagnosis. These are neoplastic. They are benign epithelial neoplasms, and they can be associated with some local bone erosion, bone remodeling. They can be somewhat aggressive, but they have this characteristic cerebriform pattern, which reflects the actual histology. So this is what they look like. They kind of look like cauliflower, and if you look at the margins of these lesions, particularly on MR, T1 post-contrast imaging, or T2 as in this case, you can often see these convolutions, and they can be extremely suggestive. The scary thing about inverted papilloma is that they can coexist with squamous cell carcinoma or ultimately degenerate to squamous cell carcinoma. So they do have to be resected in total, and they do have to be followed for quite a long time. So this is a patient with recurrent inverted papilloma, and you can see, I think, that really nice multi-convoluted pattern of disease looking like that cauliflower in the maxillary sinus. But notice this really interesting little appearance here, this little osseous strut along the anterior wall of this maxillary sinus. That strut shows you the site of attachment of the papilloma to the walls of the sinonasal cavity, and it's imperative that that strut be resected in order for there to be complete resection of the lesion and to avoid recurrence. So you can see that obviously easy on CT, but if you go back to the MR, you can actually see it as well. And your interrogation of a scan in a patient with an inverted papilloma should include a search for these lesions, and sometimes they can be very big osseous struts, kind of odd looking. This one actually continued all the way into the nasal cavity on the initial examination, so look for those little struts. They can be very helpful. The juvenile angiofibroma we've heard about previously. This is a benign sinonasal neoplasm that can again be locally very destructive and can also be recurrent. There is a very typical demographic, adolescent males presenting with epistaxis, but sometimes without epistaxis, just nasal obstruction. And the hallmark on imaging is the presence of these large flow voids, very hypervascular tumors. They typically do invade the skull base. They originate from the sphenopalatine foramen, so lateral growth into the pterygopalatine fossa, and then through the pterygomaxillary fissure into the infratemporal fossa is very characteristic, but it does not have to occur. There can be a whole lot of skull base invasion associated with these lesions, and they do often require post-surgical radiation to clean up disease that is really inaccessible because of that skull base erosion. So there's also a big category of fibroosseous or cartilaginous tumors that can occur in the sinonasal cavity, and fibrous dysplasia is one of them and probably the more common one. This is kind of the classic ground glass appearance that you see, but remember that only occurs about 50% of the time. 25% of these will be either homogeneously dense and even completely cystic. This can be a hard diagnosis on MR. So if we look at this MR case, really does look actually, again, quite aggressive, enhancing, which always seems sort of counterintuitive to me. Why would something that's called dysplasia enhance? But it does. But also note that very low T2 signal and the fact that ultimately these lesions pretty much stay conforming to the shape of the original bone despite a lot of distortion and expansion. And meningiomas do occur in the sinonasal cavity, so these are the most common quote-unquote brain tumors. So if only 2% of these occur extracranially, that's still a fairly significant number. These occur more commonly in the nasal cavity than in the sinuses, and like elsewhere around the brain and in the head and neck, hyperostosis is a very common appearance, and they do tend to be relatively dark on T2. So moving to the malignant end of the spectrum, this is a very abbreviated list of the WHO classification from 2005. And broadly, these can be considered into multiple categories. The most common would be the epithelial ones, and the most common of those is squamous cell carcinoma. But there are a variety of soft tissue tumors, lymphoproliferative disease, with lymphoma on the malignant end of that spectrum is quite common in the sinonasal cavity. The malignant end of these bone and cartilaginous tumors, so chondrosarcs and osteosarcs can occur there. And then a variety of neuroectodermal lesions, including the esthesioneuroblastoma, and we'll look at a few of these. So sinonasal squamous cell carcinoma, this is the most common sinonasal malignancy. So more than half of the malignant tumors that you'll see in the sinonasal cavity will be squamous cell carcinoma. And these occur mostly within the sinuses, although a quarter of them do occur in the nasal cavity. When they do occur in the sinuses, most commonly they'll occur in the maxillary sinus. And there's nothing particularly specific about their appearance. They are just an aggressive mass. They tend to grow outside the sinonasal cavity into the surrounding soft tissues. If they're near the orbit and brain, they tend to grow there as well. The imaging appearance is really nonspecific. So moderate T2 hyperintensity indicating their cellularity, moderate contrast enhancement, but just a generally aggressive pattern of involvement of the sinonasal cavity. So because more than half of these tumors are squamous cell carcinoma, I always find it helpful to look at a tumor and kind of ask it, tell me why you are not a squamous cell carcinoma. So there's a few clues that you can look at to say why a tumor might not be a squamous cell carcinoma. So as we saw, 75% of them occur in the sinuses. So if it's in the nasal cavity, you might want to consider something else, but remember, it could absolutely still be squamous cell carcinoma. If it has some of the unusual and kind of specific density and signal characteristics, you might think of something else. If it's bright on T1, we might think of a sinonasal melanoma. If it's very bright on T2, an adeno-CA or chondrosarc, and we'll look at the appearance of these lesions. If it does show diffusion restriction, you might think about lymphoma. And then if there's an interesting matrix within it, a chondrosarc or sometimes an esthesio. And of course, if the demographics are wrong, if you are looking at a young patient, you want to think about a rhabdo. So again, sinonasal rhabdomyosarcoma is the most common tumor we'll encounter in children and young adults, but there is nothing particularly distinctive about its imaging appearance, and it really does look like squamous cell carcinoma. It's really only the demographics that will help you here. An aggressive mass growing outside of the sinonasal cavity, orbital intracranial extension. Again, it's the demographic that's going to help you. So as I mentioned, tumor location can be helpful. The tumors that do occur in the paranasal sinuses, which is most of them, are squamous cell carcinoma tending to occur in the maxillary sinus, and then adenos have a predilection to occur in the ethmoid sinuses, and that can be helpful. But this long list of tumors do have a predilection for the nasal cavity, including esthesioneuroblastoma and SNUC, as we will see. So adenocarcinomas do have some clues associated with them. The predilection for the ethmoid sinus is helpful. And then on T2 weighted images, these often have much brighter T2 signal than squamous cell carcinomas. Certainly that combination of findings, presence in the ethmoid sinus and that very high T2 signal can be extremely helpful. And these do have two different broad subtypes. The salivary type, the adenoid cystic carcinomas, which are seen more commonly in the salivary glands, also do occur in the sinonasal cavity. There's the same problems with perineural tumor spread as we see in the parotid gland, as we've seen earlier. But they are much less common in the sinonasal cavity. And then there's the non-salivary subtype of adeno-CA with both intestinal and non-intestinal subtypes. Another common nasal cavity tumor occurring in the superior nasal vault is the esthesioneuroblastoma, also known as olfactory neuroblastoma. So these are very frequently associated with transcranial extension. Again, they start in the superior nasal cavity. And when they do invade the intracranial compartment, there is often this marginal cyst. It's non-neoplastic. It occurs at the interface between the tumor and the dura, so that is a really very helpful feature, not entirely specific, but again, a really good clue that that may be what you're looking at. So original descriptions of this tumor talked about calcification. I think that there's a few cases of calcification floating around that we all share for these lectures. Frankly, I see this, very, very uncommonly, and I think I really do need to modify this lecture. I don't think that this is actually a common finding, but if it does occur, this is what it might look like. The SNOC is something that we see quite commonly. So this is another neuroendocrine tumor, typically very high grade. This is a really bad actor. There's very aggressive local growth. There's nodal metastases and then distant mets that occur relatively quickly. These can grow extremely rapidly. Again, nothing specific about their appearance. They're super aggressive, very commonly invade the orbit and the intracranial compartment. You can see this punched out pattern of bone loss. There's typically no bone remodeling or expansion, as you can sometimes see in esthesioneuroblastoma, just punched out bone loss, very, very aggressive looking. So a new lesion that was described in 2014 is the SMARCB1 deficient sinonasal carcinoma. A bunch of us who are actually sitting in this room wrote up the first imaging appearance. We had 17 cases from multiple institutions. Again, there is nothing particularly specific about this tumor. If you're sitting in the tumor board and your pathologist describes a rhabdoid cytopathologic appearance, you might suggest, because I think that this tumor is not that well known in clinical and path communities, that maybe that rhabdoid appearance might indicate that this might be a SMARCB1 tumor. Another just superior nasal cavity mass, very aggressive. Sometimes you may see this interesting pattern, and we saw this in about 6 of our cases, of just a periosteal reaction, probably just indicating aggressive bone loss. Sinonasal lymphoma looks like lymphoma elsewhere. It is homogeneous. It does often expand bone and push more than invade, but it can go either way. Moderate T2 hyperintensity because of its cellularity, and diffusion restriction may be helpful clues. Melanoma is distinguished in the melanotic subtype by high T1 signal, but many of these cases are amelanotic, in which case they are indistinguishable from every other tumor. These are very, very bad actors with less than 15% 5-year survival. Again, remember to look at your pre-contrast T1 weighted images to look for that clue of high T1 signal. Chondrosarcs do have that unusual chondroid matrix, and the chondroid composition makes them very, very bright on T2. They have a predilection to be along the septum, and those can be clues that you are dealing with a chondrosarc. So pre-treatment mapping, that's really our role, and we are particularly looking for extension outside of the sinonasal cavity into the intracranial compartment, the orbit, perineural disease, and regional nodal metastases. We wanted to find the entire volume of disease for our clinicians. So when we look at intracranial extension, it's important to distinguish extradural disease from intradural disease. Seeing edema in the brain is not specific for intradural disease, but seeing parenchymal enhancement does indicate that you have parenchymal invasion, and obviously the prognostic and disease management implications are different. The dural involvement can be extremely subtle, so you want to look carefully at that bone involving the anterior skull base for really subtle areas of enhancement. Again, this doesn't preclude complete resection, but is important for the surgeons to know. Similarly, bone invasion in the orbit does not necessitate enucleation. You have to traverse the periorbitum. And seeing a clean black line like that is a really comforting sign that the tumor has not invaded the periorbitum. When you see loss of that black signal and instead gray signal, and certainly if you see loss of that extraconal fat, you know that the tumor has invaded the orbit proper. And of course, in this case, the tumor is touching the optic nerve, so we know there's actually intraconal disease, and this patient requires enucleation. We'll hear much more about perineural spread in a bit. Most commonly, this will affect V2, as in this maxillary sinus tumor going through foramen rotundum. You need to look carefully at the skull base foramina and the cavernous sinuses to look for evidence of perineural tumor spread. We often don't think a lot about nodal metastases in the setting of sinonasal tumors, but many of them do go, particularly things like esthesioneuroblastoma. So you want to check those retropharyngeal lymph nodes and also the upper jugular nodes on a variety of different modalities can show you those nodal metastases. So I'll finish up with post-treatment imaging surveillance, and we're really going to pretty much do what we did previously, try to map the disease and tell the difference between the disease and those post-surgical changes. Flaps make our life a little bit difficult because they can actually simulate tumor, and again, we're going to look carefully at our skull-base cavernous sinuses, those regional nodes, and occasional intracranial metastases. We're going to try to not let our clinicians rely on PET-CT to look for these variety of things that they really cannot tell the difference. So this patient had a resection of a maxillary adenoid cystic carcinoma, and you can see that that maxillary surgical bed has all sorts of tissue in it. This bright tissue, I think we can feel pretty comfortable saying is secretions, but what is this soft tissue mass? It has interesting white striations in it, and a kind of an interesting course. It seems to be kind of flipping in there. And what this is, of course, is a temporalis muscle flap, not to be confused with recurrent tumor. These can enhance as they sort of denervate, and sometimes you can look up and see the donor site in the temporal fossa. This patient, 15 months post-maxillectomy, we can see that striated soft tissue mass rotating in from the temporal region, but more important than that, of course, is that abnormal enhancement in foramen rotundum, and then actually some antegrade spread down foramen ovale and recurrence of this disease. Esthesios, when they recur, can look, the recurrences can look very much like the primary, and these little intracranial cysts and nodular dural enhancement should alert you that this is most likely going to be metastatic intracranial disease or intracranial recurrence of esthesioneuroblastoma. Of course, in this scan, we can also see an enlarged retropharyngeal lymph node. Always need to look at the bottom of those scans and be alert to those possibilities. So I'll finish up with a couple of things to remember. Squamous cell carcinoma is overall the most common sinonasal malignancy, over 50%. So you may want to think of it as a squamous cell and then maybe come up with some reasons based on unique features as to why it may not be. So some of these unique features might be the intracranial cysts in esthesioneuroblastoma, maybe high T1 signal in melanoma, maybe an unusual matrix in a chondrosarcoma. But again, you know, our primary role is accurate tumor mapping, looking for extension outside the sinonasal cavity, whether it's into the orbits, intracranial compartment, or into skull-base foramina, and the cavernous sinuses. And that's really the value added that we can bring to the table. So thank you very much for your attention. And I think there's a break now. I think I'll break.